repost your publications as well. Good morning, everyone. It's a pleasure and an honor to be here as a moderator in this panel to ensure access through the management of populational health. I would like to thank Leonardo Coelho, Paulo Rebelo, the president of ANS, Leonardo Coelho, executive director of AON, Mr. Javier Bayona. It's a pleasure to welcome you here this morning. Thank you for being with us. Thank you for having me. These debates are very important indeed when we think about populational health. These are the most important topics. This is a matter of concern throughout the world. We're referring to access to healthcare. The second topic has to do with reducing costs, including technology, of course, and how to make sure, while we make sure healthcare is provided with the top quality possible. So again, how to make sure there's access to healthcare. One of the problems we're faced with is the interest in health prevention. It has to do with populational healthcare. One of the most important things in our case is the fact that we have a very fragmented medical practice, fragmented in several attention areas, hospital, outpatient wards, offices, diagnosis support. Everything is very fragmented. In our country, and as well as in other countries too, this is a fragmented support so that you cannot provide good populational health. We should have professionals that are familiar with the promotion of healthcare services. So it's indeed a very interesting panel. I would like to kick us off with Dr. Javier Bayona. So we would like to hear his experience on how to manage populational health from his point of view, of course. Thank you for being with us, Javier. Thank you for having me. I'd like to share my screen. Could you please show my first slide? Well, these are my conflicts of interest, first and foremost. They're related to my scientific/professional activity. I worked for the Catalan Health Institute for over 20 years. A little over 20 days, I joined the Catalan Agency for Health Quality. I am part of the Community Medicine and Family Health Association. I've been a consultant for several programs there. I'm also at the Sanitary Health Management in Catalonia. I believe that in Latin America, you follow these same principles that we apply here in Spain, as far as these things are concerned. In order to ensure access through population health management, we must understand that the sanitary system, the water and sewage treatment facilities are important. However, there are other important characteristics: lifestyle, the workload, the education of populations, the work conditions, living or housing, the food quality. All these things have more influence than the water and sewage treatment systems per se. So sanitation accounts for 15% of the quality of health. Other studies indicate that it can reach up to 25%. So the main reasons are away from the sanitation per se. These water and sewage treatment costs a lot of investments. So that's not directly related to health results. Of course, we know we must provide that initial investment, that initial expense, and then there's a curve from a certain point of investment, budget allocations. From that point on, health won't improve. Clinical practices and sanitation policies should be evidence-based. What do I mean by that? So we should focus on the decision-making process and the clinical practice, taking into account populational values or the people's values, taking into account that you have to make shared decisions. Only then populations will feel empowered to adopt those measures that will matter the most to them. So what is value-based practice? The clinical interview has to have quality. And as a backdrop, there must be some clinical reasoning. So decisions are shared with those that are interested the most. You have to adopt a strategy from the National Analysis Service or from other initiatives. And of course, that requires teamwork, most preferably in a multidisciplinary fashion. Studies show that sanitation systems can perform different actions, and some of them do not add value to the health of populations. But once they are installed, there's a cost associated to it. We have to apply the Sutor law. William Sutton would do that. Where are the practices that do not add value? The money saved there can be then invested in those actions that can add value. Michael Porter said we should have health objectives that would make sense to patients. Everything that is invested in sanitation that can improve accessibility, clinical practice overall, that could be measured. It should be measured. Sanitation services should, according to the needs of the populations and the different types of diseases. There's this triple objective. Once we have taken action to provide accessibility in sanitary services, once we achieve that, we have to make sure the health of the population is increased, patients' experience is increased at the most reasonable cost possible. So these are the premises I would like to show you so that we can provide good access, taking into account healthcare of the population. So that should be based on community activities. Primary care is very powerful, it's very present, and everything should have the support for all the healthcare or specialized healthcare throughout. I believe that this is helpful, and I'll be available to answer any questions you may have in the end. Thank you. Thank you. I truly understand when you talk about lifestyle as a very important aspect of populational health. And lifestyle, sanitation is marginal when compared to lifestyle. And your point about primary care was on point. Let me ask Leonardo now. What's your take on the possibility of providing more services on education, health and education, just like Javier mentioned, as to the health objectives, maybe placing more emphasis on the health or the education of people. Good morning, everyone. It's a pleasure to be with all of you this morning. This conference is just amazing. It gives us the chance to discuss very relevant topics. When we talk about access to healthcare in Brazil, I think we have come a long way. We're still in a very fragmented industry, just like you said at the beginning. This is indeed a major hurdle. But as a consultant, we believe that corporate healthcare is getting stronger and stronger. Companies are more and more concerned about occupational and healthcare. Companies are taking the center stage, and patients too. So you can add technology. Primary care is very present, and you are combining the online and the offline worlds. We can see that happen both in providers and insurers, and much more care on mental health, prevention, and education. We've seen a major increase in remote tools. Telemedicine is one of them, among others. These services end up connecting all these elements together. when we look at this entire scope, we know how hard it is, how difficult it is to connect these players within that industry. So when we look at the Spanish model and some other models in Europe, Brazil does have the public health system as a major player. However, health in Brazil still rely on the private initiative. We see many tools being implemented, more advanced health management system to treat chronic patients or specific diseases, patients that suffer from specific diseases. So the population is becoming more and more aware of these tools. The pandemic sped up the entire process. It allowed us to experience that connection from remote primary care with other types of services. We see that happen, and that is an actual change when we look at the Brazilian health industry. Thank you, Leonardo. The way I see it, you believe programs implemented by companies for their employees, taking into account prevention and special attention to chronic patients. But just like Javier talked about how important it is to have primary care as one of the key elements to improve the health of the population overall, I would like to take this opportunity and ask Dr. Paulo Rebelo, what can we do in the healthcare industry to promote not only access, but looking for primary care as their number one focus of people and corporations as well, when compared to the hospital-centered care. It's not only more expensive, but it won't necessarily address the problem and won't provide a continued line of care, just like primary care. I don't know what you think about the lack of emphasis in primary care.
Thank you, Manuel. I had a slight problem in the beginning. My connection froze, but I'd like to greet you and greet Javier. I'd like to thank Dr. Chosier for the invitation. It's really a pleasure to be here. This is an important subject when it comes to population health. It's an important assumption if we want to guarantee not only access, but egalitarian access to health. And the agency has been looking into the need for us to make an adjustment in this administration so that we can continue to maintain our focus on continued high quality access to health. From that perspective, we've been trying to change the role of the actors in this sector, and so that the producers of care, the caregivers and beneficiaries are all aware of their autonomy and their condition, with an increasingly more qualified agency, increasingly more efficient, so that we can regulate the industry, and reinforcing the importance of collaboration between the contractors and contractees, connecting the roles of the several different players involved. The supplemental health plus the collective business plans represent 60%. So the contractors are a fundamental organization in this change that we intend to make through health management, moving towards this holistic model based on value, promoting the improvement of the system and encouraging better care and the adoption of health prevention and health promotion programs, the agency already gives incentive to these programs, and these amounts can be extended to these new programs. There's also a bonus that is paid to operators that adhere to this program. So we firmly believe that by placing the patient at the center of the discussion, we will provide a high quality health care and health treatments in the industry as a whole. Well, you mentioned the incentives provided by the agency. And on the other hand, we see that companies are not maintaining their level of success. Or if we look at the triangle showed by Javier and the goals that we must set in terms of obtaining better quality of life, highly motivated by better lifestyle, which is responsible for most of the chronic and degenerative diseases. I wonder if the agency would have new tools to improve this incentive to companies so they can invest more and encouraging people to look for a better lifestyle and to promote self-care in a better way, because everything's related to education in health, but that requires a lot of investment. Disseminating this type of information in the population, especially if the population is constantly renovated due to contract terminations and whatnot. So many of these services are often lost in the contract. So which additional incentives, I wonder, could the agency promote to improve that situation? Because my specific perception is that probably with these incentives, we have not been able to encourage the companies to make higher investments for people to adopt a healthier lifestyle and to produce better indicators from the perspective of the population. Well, you're correct, Manuel. There's this promo-prev incentive, and I believe that over time there will be, and companies will see, and Michael Porter, his book specifically says that over time we are going to have that benefit, and I obviously agree that this is too incipient, adhesion is too low. And to give you an idea, these programs that have been approved in the agency, we have over 1,000 programs, and they encompass a little over 1.5 million beneficiaries, which is too low in a sector with 48.6 million beneficiaries. So that's one thing that we have to talk increasingly more frequently. There's also CATEC, a technical chamber that's open to discussion. The agency has been allowing contractors and operators as well as providers to be within one same space to promote discussions, because as you said in the beginning, there are structuring challenges in the sector. There's a demand from the population for new technologies having an increasingly greater impact on costs, and we really have to change that perception. And it is through the promotion of health and prevention of diseases related to occupational health that will be able to bring down these costs. And above all, as I mentioned, the participation of contractees is important if we want to encourage these people to become aware that it is only through self-care and through the adoption of physical exercise and a healthy diet that we're going to be able to reduce these costs. Otherwise, we'll not be able to bring these costs down. Thank you, Paulo. Thank you for your comments. Javier, in your opinion, what are the best investments that could be done to encourage the population in general to adopt a healthier lifestyle that is enough to improve the health indicators? I mean, what are the tools that the healthcare system can use to encourage and teach the population to adopt a better self-care and better control their lifestyle when it comes to everything, the consumption of uh, greasy foods and consumption of sugar, smoking, alcohol consumption. I mean, all of these things that affect the population in general. Well, I have an important bias because the health system where I work is clearly different to yours, and this maybe might lead me to say something that is not feasible in your environment, in your setting. And given this bias, or given our differences, well, let me tell you, in my country, we are making significant efforts with few economic resources behind them, which is health for all policies. What does that mean? It means that in the government health care plans, what they did was an agreement for all departments when they implemented an initiative that they take into account that the most important values of society is the well-being of the population. In this healthcare system, we should also think about the emission of gases that might lead to climate change that have an influence on the population health. Pollution is a risk, a factor for early death due to cardiovascular reasons. There are policies that encourage the adoption of sports in community by making it easier for people to do jogging and other types of sports that have no high costs, but which but that encourage the population to be aligned with a healthier lifestyle. Of course, the consumption of toxic products is another thing. We should encourage people to bring down their consumption of alcohol and tobacco, but that has to be aligned with the policies of primary healthcare teams and policies and other policies that might lead to the decrease in the consumption of toxic products. In that regard, I would globally place a bet on the program that I mentioned to you to have healthcare crisscrossing all policies. There is a component now that does not encourage service providers and clinics, labs, hospitals, I mean, service providers in general, keep in mind the general health of the population that they serve due to the compensation system, which focuses on the provision of services and not on the population. The higher the amount of services provided, the higher the compensation, and that's a business. On the other hand, we experience a drama in that the population sees healthcare, and maybe that's a global phenomenon, as a consumption of service and not as health as we know it, as population health, from a conceptual standpoint. And as consumption, the population needs or wants to have access to it. Given this dilemma between what the population thinks about healthcare services, seeing it as a consumption service, and service providers seeing it as a production line that's perfect from the point of view of service provision, what is the best rationale or the best recommendation you would make in this scenario that is apparently so chaotic in terms of trying to obtain a better population health management? Well, the healthcare systems, the evolution is different in the entire world, and the resources allocated are also different based on different parameters. If I had to focus on the production system, and if I wanted it to be accessible at reasonable prices for the population, I would place a bet on the proximity services, similar to the ones that we have in models of different countries where we have national healthcare systems, where the community and the social and sanitary services and primary care are the first level of access to health services. And the first level of access is open 24 hours a day with a minimum service for the weekends. And from Monday through Friday, it's open full time in hospitals, and especially the tertiary services at the level of hospitals. By choosing a continuity that must occur between the primary and specialized care, and through protocols and clinical guidelines based on evidence, not only on evidence. And this has an impact on the services provided to patients with special needs. If we want to help them choose the best path to achieve better health. And of course, that reduces the amounts received by some providers or services, but the quality of service increases. And in a system connected like that, from a macroeconomic standpoint, the entire system would win, of course, especially citizens. Thank you, Javier. I'd like to pick up on what you said and ask Paulo, because I could summarize synthetically what Javier mentioned as the hierarchization of services, something that could be possible in more vertical private systems, and maybe, of course, people want a free access, and free access is not hierarchical. If access is hierarchized, it ends up having a lot of waste and too little synergy in terms of the healthcare management of people, especially in terms of the continuity of assistance. How do you see the possibility of the agency contributing to encourage the hierarchization of medical and hospital services? Well, in line with what you mentioned, I think that in Brazil, we have this model where you pay by procedure. There are other alternative models, though, but this model is being tested in several different countries. He's breaking up. And I believe that the agency's been encouraging through guidebooks. We have a regulation that places recommendations. We do not force operators to adopt any given model. we believe that it is through co-creation that we're able to create a new model. And I think that this recommendation of a model based on value will change this paradigm and imply paradigms and be transformed into a cost reduction process. Of course, we should not lose sight of the fact that we should be keeping our focus on the best patient outcomes. And the agency has been encouraging the construction of healthcare indicators to serve as a guideline for that construction. And through increasing social participation and by encouraging competition, that will lead to a change in the model that is adopted. As you said, it's only that way through co-creation that we'll be able to find a reasonable model that is adequate for our industry. Thank you, Paulo. I want to ask Leonardo more or less the same question. Leonardo, could you review your experience? Ale is a global large broker with customers all over the world. So how do you see the possibility of fostering hierarchization of the access to the healthcare system with a focus that is not so much on consumption, but rather one that is focusing more on the health of the population rather than on the provision of services? What's your opinion about that? Well, I'll make an analogy about what Javier said. When we talk about fostering public policies, and that depends on the model adopted by the country. And in Brazil, we think there's also room for private initiative to create its own incentives and its own strategies. So what we see from the perspective of change is that first, it is a change of a mindset through the HRs themselves. So I think that companies now understand increasingly more that managing population health is fundamental if we want to deal with this dilemma, which is the dilemma of the fragmentation of the supplemental health system, because consumption habits are really very strong in the health sector. And especially if we take into account a fragmented system, we see that there are many companies trying to find a different format for their products, whether it is by implementing healthcare administration models or by incentivizing its collaborators, by engaging collaborators in healthcare programs or in well-being platforms to prevent and promote health. That's also seen as an added benefit to products that are made available by operators, insurers, but also as part of the HR strategy of these companies. We also saw a greater openness to discuss healthcare assistance models, and regardless of whether the operator's model is verticalized or not, models where the company itself is willing to adopt access products that are more hierarchized, whether it is through more technological tools that allow for a sublayer of products, or by means of programs established in partnership with the occupational health sector of these companies, through companies with their own outpatient offices, or companies that work with advisory boards in helping promote and implement these healthcare programs, but all of them in line with these models. We know that Brazil is a huge country. We have challenges related to coverage of our network. And of course, I'm referring to the private market. So that's a bit of our perspective.
Thank you, Leo. Let me just make a couple of comments and then I'll turn the floor over to you. Let me start by saying that modern medicine, and especially the movement to cities in the 50s and then in the 60s, that's a dilemma faced by the entire world, which is medicine. A huge amount of needs and finite resources. This is something that's been discussed the world over. But the major challenge is to have these three pillars. How to make sure you have healthcare, this iron triangle, retention of costs, quality, and access. How to make sure you balance these three pillars: quality, contention, and access. That's our challenge, so that we can have access, we can ensure access. Fortunately, given the technological revolution, costs go up much faster than inflation, than the capacity to generate wealth. So health is always faced with higher and higher medical costs. Very few countries can balance that increase in costs and at the same time generating more wealth. Our private system, in particular, is faced with the same dilemma. How can you make sure populations have access at a reasonable cost, creating new technologies at the same time, something new, and managing that demand that a population that sees health as a consumption service, as a service. So we should focus on populations and prioritize their lifestyle, their habits. This is a challenge we're faced with day in, day out. Of course, in a country like ours that is faced with economic issues, it's difficult to give more access to private education because of growing costs. Our population aged much more quickly than that of Europe. Lower birth rates, and people living longer despite the pandemic. So ours is a country that embraces technology very quickly, but the costs are high. Consumption is encouraged, not always in the way that should be. How can we therefore ensure access to private healthcare? So this is my closing remarks, but I'll turn over to Javier and then Paulo and Leonardo to wrap things up. Thank you for your comments, and thank you for sharing so much knowledge. These are decisions that are made in the political realm. Healthcare is key for all citizens. And this has to do with the legislative. At the operational level, providers and insurers can do many different things. They can reduce access barrier, and the most important barrier there is the cost. Patients that would like to have access to those services. The second barrier is the quality of service you provide. Just like I said at the beginning, that has to be based on the value, the added value that these services can provide. All therapeutical and clinical activities should be evidence-based to show that what's being done will provide more benefits than harm to the patient, whoever they may be. Not doing anything can be a good treatment, and there's no cost associated to it. Professionals have to have incentives to give the population they serve access to whatever can add value to their health. And move away from bureaucracy overall. It has to do with this, with the skills and the services they can provide. For example, if there's a specialist surgeon that specializes in cataract, there will be more cataract operations there than in other regions where there's no such a specialist. Of course, specialization is necessary, but you have to associate that to the cost to make sure it is providing more benefits than harm, as I said. So there are three levels: a political decision, an institutional decision on the part of the organization, be it the health provider or any other corporation, and those professionals that actually provide those services, that play those roles. Thank you, Javier. Over to you, Paulo, for your closing remarks, please. It's important to have a regulatory framework so that we can make sure the product makes sense to patients, can help them manage their health. It has to be economically sustainable. It should fit the pockets of companies and families. You have to have some good ratio between quality and price. Fewer and fewer companies and families have to afford their health management. The population is aging. The prevalence of diseases that are more and more chronic, non-transmissible. These are long-term, high-cost treatments. This puts even more burden on the costs, healthcare costs. This is a very interesting discussion. This is what we need, democratic debate, so that we can evolve to make sure families can afford their healthcare with the appropriate treatment, to make sure at the same time that there's sustainability for the entire system. So these discussions are all indeed very important so that we can move along. It's important to include every player in the industry. When Leonardo talks about the HR departments, it's important that they discuss these issues. Companies used to have more of a secondary role. Now they take center stage, and that's important. So absenteeism goes down when employees have good health care. The regulators will have to define policies to minimize that friction so that we do have sustainability while providing more access to population. Thank you, Manuel. Thank you. Thank you, Dr. Paulo Rebello. It was an honor to share this conference with you. Leonardo, your closing remarks, please. We can't hear you. I'm sorry, I was muted. Thanks, Manuel. Thank you for inviting me. This was indeed a very interesting discussion. I believe we'll keep on moving along. There's no silver bullet to our dilemma, I believe. I think we have come a long way when we talk about the importance of companies and their HR departments, but also more involvement of major players, insurers, providers, healthcare providers themselves. They've understood that the equation has to make sense, balance between cost and quality. That notion that we must concentrate in a more generalistic medicine to make sure we have to go back to the primary care. Specialization is very important, has to be there, but it has to be very well directed. I'm a firm believer of the correct tool for the right problem. Telemedicine is a very productive tool, and it does not do away with the physical care of doctors, with the physical presence of doctors, but that has been helping to make sure people have access, not only for employees, but their relatives as well. And this is supported by the agency, all operators, all providers, to provide better products, to offer reasonable costs, providing new alternative mechanisms with all the innovation we have seen in Brazil. Once again, thank you. Thank you so much for inviting me, for having me. Thank you. Thank you, Leonardo. This concludes our conference. I would like to thank Josier, the entire FIS team. Thank you, Dr. Javier Bayona, once again. Thank you, Dr. Paulo Rebello. And once again, thank you, Leonardo Coelho, Aon's executive director. Thank you. I think we have a very positive discussion, important discussion to the industry, and of course, ensuring access, a very relevant topic for many countries with new technologies and lifestyle associated to climate-related issues. Based on what we've seen in COP26, we haven't been able to address the climate change solutions that are reasonable throughout the world. We may not be taking good care of ourselves, not even the world in which we live. We have to think about these things. Anyway, so thank you so much once again. Goodbye.